But I'm going to proceed with our next speaker, and that's Dr. Ziad Faaz Ashraf. He's one of our residents in CT surgery who also has a postdoctoral position at University of Pittsburgh and Carnegie Mellon. And he will be talking to us about the stage treatment of Ebstein's anomaly, our cone after Starnes results.
Hello. Thank you very much for the kind introduction. My name is Faaz Ashraf. I'm one of the I6 residents, CT surgery residents here at the University of Pittsburgh Medical Center. Thank you for the opportunity to present today. Today I'm going to talk about the stage treatment of Ebstein's anomaly, our cone after Starnes results. A bit of a similar summary to what I presented last year from the paper was published in the JTCVS, but with some slight updates of some new short-term outcomes with extra patients we have. I have nothing to disclose. So, in its most severe form, neonates with Ebstein's malformation may present in cardiogenic shock with characteristic features such as a circular shunt, a massive RV dilation resulting in LV compression, and severe tricuspid regurgitation. In neonates with intractable cardiogenic shock, surgical intervention is required. The modified Starnes procedure uses a patch to exclude the right ventricle, and a systemic to pulmonary shunt is placed. This allows the rescue of neonates and is reproducible at many centers. However, it previously committed patients to a univentricular physiology. The cone operation, in comparison, aims to repair the tricuspid valve, repositioning it to its anatomical position, leaving a biventricular result. However, it is high risk for the sick neonate in shock due to reasons such as prolonged operative times, high RV afterload, and small friable leaflets. We believe in a staged approach, which we first initiated in 2019, where we were able to rescue infants with severe Ebstein's anomaly and intractable heart failure using the modified Starnes procedure. And we have previously shown that we can now convert them to a biventricular or 1.5 ventricle pathway using the cone operation later. Today, I present 19 patients from this institution who underwent this staged approach between 2019 and 2025. So, looking at the demographics, in addition to Ebstein's anomaly, 7 of the 19 patients had pulmonary atresia, 3 had pulmonary stenosis, and 7 had pulmonary insufficiency resulting in a circular shunt. All of these patients were critically ill before their Starnes. 5 of them were on ECMO. Of note, and this is pretty important, 15 of the 19 patients in the series had their Starnes operation at an outside hospital. 14 patients underwent their Glen at a median of 6 months old. The median age at which patients with a Glen who underwent their cone repair resulting in a 1.5 ventricle circulation was 28.5 months, whereas the median age of those who underwent a cone for biventricular repair was 12 months of age. As shown on the graph here on the screen left, the reasons for the large variance in the time of operation was really reflected by when these patients were referred to us from an outside institution. All patients pre-cone underwent a cardiac cath and echocardiogram. The RV systolic pressure on cardiac cath ranged from 11/4 to 47/6. The flow of blood through the Starnes fenestration patch was used as a surrogate marker to measure RV pressure generation, which is called Starnes regurgitant velocity. Our median in this series is 1.7 meters a second. And 9 of the 19 patients had a pre-cone cardiac MRI, where the RV end diastolic volume index was 1/3 of what we call in the normal range. 4 patients of the 19 were converted to a 2-ventricle repair, whereas 15 patients with a Glen to a 1.5 ventricle repair. In summary, the repair went as follows. Firstly, the Starnes patch was fully removed. Then the cone repair was undertaken involving extensive mobilization of the leaflets into a cone structure that was sutured to the anatomical tricuspid valve annulus. In addition to the cone repair, 15 patients underwent pulmonary valvoplasty. All patients underwent a fenestrated ASD closure, and the median hospital stay was roughly 1 week. I'm just going to give you one example. This is one of our first patients back in 2019. And this patient in our series with Ebstein's anomaly and pulmonary atresia. The newborn echo is shown here. The patient then underwent a modified Starnes procedure, and the post-Starnes echo is shown in the middle. This patient then underwent a Glenn and pulmonary valvotomy at 4 months of age. And finally, she underwent a cone repair at 19 months of age, resulting in a 1.5 ventricle circulation. On the post-cone echo, you can see on the far right, you see blood flowing through a competent tricuspid valve, good RV function, and blood flowing through a pulmonary valve. For our follow-up results, I'm actually going to reference the paper we published last year, which we actually went into detail their short-term discharge follow-up and their mid-term outcomes. There's a lot of data here, so I'm actually just going to summarize it into this table for you. This is for those 11 patients in the paper we published last year. As you can see on the discharge echo, when we looked at tricuspid regurgitation, most of the patients had only trivial to mild tricuspid regurgitation. However, of the 5 first patients in that series, where we had subsequent follow-up with a median of 3 years, again, we had mostly trivial to mild regurgitation. When we looked at RV function on discharge echo, most of them had normal function. 2 patients on discharge had severe RV depression. However, on follow-up of the first 5 patients, a median of 3 years, of the 2 patients who were discharged with severe RV depression, 1 patient was actually able to improve and recover their RV function to only moderate depression. So all patients had no new heart block, all had good functional status at follow-up, and there were no reinterventions on the tricuspid valve. Now this is something I'm going to talk about in the next slide, but no metric of RV function on pre-cone imaging we found was correlated with post-operative RV function. And this is a table here where we looked at, on the paper last year, on the echo, the Starnes regurgitant velocity, and compared this to our post-operative RV function. We looked at cardiac cath, RV systolic pressure, and of the 11, 5 had cardiac MRIs, and RV end diastolic and RV end systolic volume index. None of them were correlated to post-operative RV function as any predictors. These are scatter plots. On the x-axis, we show the post-operative RV function, normal all the way up to severe depression. On this first chart, we have the Starnes regurgitant velocity from echo. And similarly here, we have RV systolic pressure and the pre-op cardiac cath. Really, there's no correlation. Some may say that some of the mild, moderate, severe depressions were lower. However, in my opinion, we just don't have enough data and longer-term follow-up to really make any conclusions here. Now, looking at the 19 patients in total, we only have discharge echoes because a lot of those patients are done very recently. So when we look at those post-operative follow-ups, so on their discharge echoes, most patients again had trivial to mild tricuspid regurgitation. And for their post-operative RV function on discharge of the 19 patients, again, most had normal to mild depression. But again, those 2 were severe depression. That was explained earlier. 1 had improved to moderate on a longer-term follow-up. There were no new heart block. All patients had good functional status at follow-up clinic. There were no reintervention of the tricuspid valve. We found out recently that of the 19 patients, there were 2 patients from earlier on who now have severe pulmonary insufficiency, which really goes to show how the importance of the pulmonary valve in these patients post-Starnes. In the limitations of the paper we published last year and now, these are only small case series of what was only 11 patients, and only 5 patients we really looked at midterm follow-up between 1.5 to 4.5 years post-operatively. As described earlier, we have a pretty simplified summary of how at this institution we deal with patients a post-Starnes procedure on deciding how to go down the cone repair. Those patients with a normal or nearly normal pulmonary valve after their Starnes, we would look at doing a cone operation at roughly 5 or 6 months of age. However, really this is all dictated by their pulmonary valve. So patients with a pulmonary atresia or severe pulmonic stenosis with a small annulus, we would look at performing a Glenn operation, roughly 4 to 6 months of age, and then delaying their cone operation and pulmonary valve repair, and if they need an RV to PA conduit later on at 12 to 18 months of age. Really, to ensure the ease of a conversion to a cone after Starnes, we've thus recommended and have published last year some guidance on how to modify and how to perform the Starnes operation to help us convert these patients to a cone repair later on. So we recommend at the time of Starnes to use firstly a PTFE patch, as this is a glutaldehyde patch is more likely to cause adhesions to the tricuspid valve, which a PTFE patch will not, or at least less likely to. And we advise to suture this patch slightly above the anterior tricuspid valve annulus, going clockwise towards the inferior annulus area, ensuring not to injure the tricuspid valve leaflets or to damage the AV node. And for those patients with severe pulmonary insufficiency, we recommend placing a PTFE patch inside the PA above the pulmonary valve, again making sure to preserve the valve. And really one last slide, something we published earlier this year in January. This is not for a patient after a Starnes. This is really describing the pathway here, UPMC Children's, for a newborn who comes with Ebstein's anomaly. So we're going to go through this flow chart. So with a patient, we want to first assess if they have pulmonary atresia. If it is potentially functional, we can try to treat them clinically. If their cardiothoracic ratio in the clinic is less than 0.8 and they're clinically improving, but with cyanosis, we can go towards a BTT shunt or PDA stent. However, for someone with anatomical pulmonary atresia or worsening heart failure, despite medical management, we would go down the Starnes procedure and then at a later point, the cone repair in the future. As described earlier, for patients with severe pulmonary insufficiency resulting in a circular shunt, we would go down the Starnes pathway and pulmonary artery closure as described in the last slide, and then a bidirectional Glenn for roughly 4 to 6 months of age, and then a cone later. And lastly, for a newborn of Ebstein's anomaly who have adequate forward flow in the pulmonary valve, who are no heart failure, gaining weight, doing clinically well, you can clinically treat them and do a cone at a later date. Only those patients with forward flow in the pulmonary valve who have significant tricuspid regurgitant heart failure would go down towards doing a PDA closure or, in very selective cases, neonatal cone. So in summary, post-Starnes, we found the right ventricle to be substantially underfilled, making the effective RV appear more hyperplastic than it may be. We were able to successfully reroute 19 Ebstein's patients post-Starnes to a biventricular or 1.5 ventricle pathway. Most patients now have normal tricuspid valve results and RV function at follow-up. And we found that the Starnes no longer commits patients to a univentricular pathway, and it is important to emphasize reversibility at the time of Starnes. Thank you very much, and thank you again for the opportunity of presenting today. I'll leave it at that.
Thank you so much, Dr. Ashraf. That was a great presentation on the midterm outcomes for this procedure. Are you planning to look more for the long-term outcomes in the future for this population?
Exactly, that's really important. Thank you for the question, important question in general. We are trying to follow up as best as possible the longer-term follow-up. However, sadly, one of the limitations we have is the majority of the patients are actually not around from this area and have a lot of their follow-up at outside institutions, making it pretty difficult. You really have to text them or text the cardiologists either across the country or across the world, where some of these patients are internationally, to try to find out how they're doing in the long run. But that's something we are trying to do.